in the HIV aging population, health outcomes for HIV-infected adults need to be evaluated in broader outcome models that incorporate non-communicable diseases, especially as these populations starting on ART when they are stable and living longer. So prior to this, we assessed the prevalence of HIV and hypertension control in our multi-disease chronic care system in 10 facilities. That's 10 clinics in eastern Uganda and 10 clinics in western Uganda. And while viral suppression had been achieved after 2 years of 90%, or even above 90% in all those patients, for patients who had hypertension and HIV, we had only achieved 67%. So posing a gap of 33% that I thought we should understand why that gap, and then seek to determine I will seek to determine the barriers to optimal HIV and hypertension control in these clinics, and also find solutions to optimize the cascade for these patients. So my overall objective is to determine and address barriers to optimal composite HIV and hypertension control in the 10 clinics. The specific objectives, I've looked at this data, and this study has been ongoing for about 4 years. So I looked at I'm taking our follow-up year 3 data as baseline data, and that's the data that we use to look at that composite that I talked about of 67%. But I've gone ahead to look at the data again in preparation for this about a month ago, and I observed there's a lot of heterogeneity in the control across the clinics, the 10 clinics. So one of the baseline, one of the objectives was also to understand the predictors of this heterogeneity of hypertension control among these HIV patients in the 10 clinics, as part of this will inform the next steps. Then after that is to kind of design an intervention that will address the barriers, and so after that is to determine the prevalence and predictors of optimal composite HIV and hypertension control. And then as one of the secondary objectives, after 1.5 years, maybe once, even when the course is over, is to look at retention in care for these patients. So I hypothesize that addressing these multi-level barriers will lead to optimal hypertension and HIV control. And I categorize the barriers at 3 levels. They could be at the health provider level, could be at the patient level, and then the clinic system. So it's a prospective cohort analysis in 10 such sites, and the proposed intervention will be based on the PRECEDE framework to address the barriers and come up with the interventions to improve the composite HIV and NCD control. So as regards to the predisposing factors, looking at the barriers, at provider level, I thought that there might be some knowledge gaps because we've had a turnover of some health workers. And even then we train them, but sometimes you find people are not living up to what they were trained on. There could be some practice gaps, looking at if people are adhering to the treatment algorithm, the SOPs, are they prescribing the medicines as per the guidelines we have in the clinics? Are they sharing the patient information and communication material that we give them as expected, or they are not? And at the patient level, I intend to interview some patients and look at, are they adhering to their medicines, or are they prioritizing ARVs and not taking their hypertensive medicines? Then there's a component of lifestyle adjustment. I know these are largely rural patients, but there are some of those that need that. And then looking at the patient practices and beliefs. Are they opting to take maybe the ARVs and taking some other thing, not taking the hypertension medicines? What are their beliefs? What else are they doing that might lead to their hypertension not being controlled? Again, from visiting some of the sites, one of the things that I look at is could it be the records that maybe there's some information that we missed? Can it be record management? For some of the sites, could we explore a one-stop, is it a one-stop visit? If I come to the facility, am I seen for hypertension and HIV at the same time? Are the dispensing windows different? If I get my ARVs maybe in the clinician's room and I have to look for the hypertension medicine, and maybe I'm even asymptomatic, I might just as well go home. So looking at health education, how much information is given out to these patients as part of the general health education that goes on in the clinics, and also looking at the clinic flow. These clinics are very different, and maybe the flow could affect the service. So what I propose to do at the provider level is possible retraining, and then again, where we find like the tools are not available, avail them, the SOPs, the blood pressure measuring machines. You get to the facility, and even when you've provided one, you find it's one big blood pressure measuring machine that rotates around the whole hospital or clinic, and then track appropriate use of these, following the guideline that we provide. Then at patient level, depending on what we will find as a barrier, also offer targeted intervention in terms of health education, also providing brochures or leaflets that have information about hypertension and on lifestyle modifications for the patients. Of course, adherence to hypertension medicine. Emphasize it. I know we emphasize a lot of HIV drug antiretroviral therapy adherence, but also emphasizing adherence and enhanced counseling for those who are not adhering. And then looking at the clinic system, if there are issues to do with the patient flow, with availing some things like blood pressure measuring machines, and seeing how that is done. Is it done at triage? We try to harmonize this. And for dispensing of medicines, from the observation of visiting these clinics, a number of them don't have a single dispensing point. Maybe supporting them to look at a one-stop center for both diseases. And in terms of the reinforcing factors, for those patients that are not, who had previously not achieved control, patient recognition and appreciation of control when it happens, I thought that would be reinforcing to sustain that. And then bi-monthly feedback to the health providers at the facilities, looking at the monthly data, and then looking at how many patients have improved as regards those who come for the visits during the month and have improved on their hypertension and sustained HIV suppression. And then quarterly feedback to the health providers in the region. For example, in the Western Uganda, the 5 clinics can get leaders of the 5 clinics sit together, and then we share how well they are doing, and that should encourage the health providers to continue doing what they are doing. So a bit of looking at the study population, I already mentioned the HIV patients within these clinics, and we'll look at consenting patients. And then consenting health providers, I intend to conduct interviews about, to understand, because we've put in some infrastructure for these healthcare providers and would expect the outcome to be different. So we'll seek to understand if there's anything that they think is a barrier that we are not seeing. And then, like I said, I will utilize the follow-up year 3 data as a baseline data for me to then inform what will go on, and then we'll collect data from patient providers, from the healthcare providers, like I said. I'll also review electronic records that we have and visit all the clinics to see the flow, to understand if there are issues as regards to the flow, how and when blood pressure measurements are done, how the health education happens, and then prospectively examine the changes in the outcome of HIV and hypertension control at 6 months, 12 months. I thought I would, for this study, for this kind of course I'm doing, it will maybe stop at 12 months, but I intend to carry on and see what happens at 18 months. So the study outcomes are in line with the objectives that I earlier shared. And the predictors, the first one is on the predictor of the heterogeneity of HIV and hypertension control that I just observed. This was not my initial objective, but when I looked at the data, I observed like very divergent findings in the 10 sites. So I thought I should find out more why it's happening like that in those facilities. And then after the intervention, looking at the composite HIV and hypertension control at 6 months, 12 months, and 18 months. And again, we look at the predictors of the control at those points. Secondary outcome will be retention in care at 18 months, and the unit of analysis will be a health facility. Of course, looking at the patient records, because we have a system that can track individual patients. As regards to the progress, I've just completed the course. We did the fall and the winter course. We just completed the winter course yesterday. And then I've had regular interface, I should say, maybe on a every fortnight with the UCSF mentor, Professor Diane Havlia, on this project. And we've looked at the baseline data, and I'm still looking at some components. Hopefully I'll be done looking at it and describing the reason for this heterogeneity by end of April. These proposed adjustments to the study, we are submitting a revised protocol for the whole study. So hopefully we'll have IRB approval by June. We intend to submit in May as the whole search protocol. And then implementation of the study, I was thinking of July. As soon as it's done, I will be ready to start, but to make sure that it's within the acceptable time, I think of August this year. And then data analysis for 6 months and 12 months at those February and August next year. And then manuscript writing should follow suit, because the data will be in control of that data. We should not have a lot of issues after that. And then the other thing is complete the spring courses in May. Acknowledgements, thank this team of the implementation science group and for giving us this opportunity to learn. We are learning a lot. The search leadership for allowing me to continue working on this, and of course the mentors. Yes. Thank you.
Thank you, Dalsone. We've almost used up all the time. So we'll have some 3 comments. Richard?
Thank you very much, Dalsone, for that interesting study. I have a few comments. One is that I don't know, I think one of the things, when you're going to present, I think you should have divided into receive models, so tell us what's going to be disclosing to your study, what's going to enable the study, and the same time what's going to be your feedback and what reinforcing factor that study. You've talked about the baseline, which you probably could have studied, but in terms of what you're going to interview, it looks like there's a lot of qualitative work which was done. So do you have any baseline qualitative to tell that maybe if you improve infrastructure, or if you told the health workers or the patients about the HIV and hypertension management will improve, so that you could know that you're using some baseline, and if you intervene to be able to tell us The third one, yes, you've already, I don't know, are you going to use the search as the sites or the health centers which are under local government, which you're going to be working on? Because the way you're talking about it's more of a cluster study and it looks like what are going to use health centers. So are you using the search sites themselves or the real health centers and local health centers in the region? Thank you very much.
Thank you. Actually,
Yeah, thank you very much, Dalsone. I think this project has moved very fast now, almost there, from the time when it was part of what in our community engagement class. And I'm so grateful to see them one items. Just a small question for one of you. What do you mean by optimal HIV hypertension control? And what do you mean by heterogeneity in that case? Those two need, if you say someone has optimal, which is a composite, HIV, they are control. Yeah.
okay, any other question? Okay.
It's a nice study. That she said so much that his comment about summarizing the conceptual framework would be ideal for us to understand, because we are doing so much in one study. It would be good if you had that framework pictorial so we can understand exactly what you are doing, what you're dealing with, what and what's your final outcome. It's a bit confusing. And then I keep on talking about heterogeneity, which you observed. It would be good if you document that, so it's an objective in itself, document it, and then you are able to find out why there's heterogeneity in the VPs that you're finding in the different clinics. But otherwise, it sounds a bit too much. In some places, it's like you're donating money to the clinics, not research anymore.
Yeah.
Mine is just a minor one. I noted some clinics have nurse-led HIV care. Just to understand, are they the ones who also manage hypertension, or is there a referral same day or next day? Just something to think about as you're designing this.
Okay.
Thank you. This is very cool. I mean, if you can improve hypertension control, that would be, it's composite. Hypertension is lagging behind HIV, and you have clearly defined the gap, which is very good. And so my question is, first of all, it looks very ambitious. The intervention looks very ambitious. You know, if you look at is that perhaps that's what you probably yeah, it's too much. I mean, the predisposing and enabling and could you bring them up? Yeah. Well, you know, I mean, one wonders whether you're going to intervene on all of these. You go on the next page. So those are predisposing factors, those are enabling, those are reinforcing. I mean, whether you're going to address all of this. So I was wondering if you can use, would that be a combi kind of thing? Like sort of come up with what are the key barriers? I know that, for example, drugs are key. Having drugs at the clinic. And of course, sometimes it's very difficult to intervene for that one, unless you tell the ministry to provide drugs. But there are some, but of course, you cannot intervene on something that is impossible for you to intervene. So I wonder whether there are some key things in the predisposing and enabling and reinforcing factors that you can say my intervention is going to be these three things. They are the ones I'm going to measure to see whether they improve this composite outcome. Because these are just too many.
Okay, thank you. Mine is just two small comments. One is a follow on Moses'. I think to answer Moses' and Flavia's comments, maybe you want to just initially understand the barriers to this whole problem. And similarly to Lillian, I've been struggling to understand what heterogeneity is. Is it facility providing different levels of success at the different facilities? Or is it that in some setups you have someone with well-controlled hypertension but poorly controlled HIV, and in others you have poorly controlled, better controlled HIV but not the blood pressure? Because it could be either way, but it doesn't come out very clear. So you will have like 2 minutes to respond and then
Thank you very much. Great feedback. For the Katuram's question about the PRECEDE model, yes, I'm going to come up with a conceptual framework, just that I couldn't put it on PowerPoint and it's still in progress. And regarding baseline qualitative data, we have it, but we've not looked at it. So it's one of those that we're going to look at. And then you asked if it will be in such settings. Yes, it will be. Looking at what I'm looking at, the available funds, it's only right that we leverage and improve on what we already know. And then in terms of optimal HIV control, thank you, Dr. It's looking at achieving viral suppression of more than 90% and hypertension control of more than 90% in the whole population. That's what I defined. And then as regards to heterogeneity, we observed that if you look at the hypertension control and HIV control, that composite outcome for these facilities, some facilities are actually doing so badly, others are doing so well. But even looking at the populations themselves, you find men in some places are doing well, and yet women in the other places are doing badly. And so I wanted to understand what are those peculiar things that maybe might be at the intra-facility level, because I looked at that. I first looked at the whole population, then tried to break it down to the facilities and observed some serious differences. So.
And you were saying you are looking at the predictors.
Yes.
Of heterogeneity.
Yes.
So there may be heterogeneity between the clinics, between the men and the women. So in a way, you have many models who are going to build.
And I need help on that one. I need help, yes. I need help, yes. Thank you. I think she mentioned about are they nurse-only visits? Yes. Sorry, I didn't describe our multi-disease model, but it has a clinical officer. Then you can escalate it to a doctor depending on the different patient observations or symptoms that they have. Thank you, Professor Kamya, for the guidance on the barriers. I thought if I do the baseline, I will not focus on all these barriers as they appear here, as they are proposed. That's why I think, like May, would maybe try to focus on those that are critical and within our control, really, and we think they can help us to achieve a better outcome. Yes, yeah. Thank you. I think I've tried to answer all of them. I've taken note of Fred's comments.
Thank you.